Now we go on to another important symposium on imaging and functional assessment of CAD. We are very fortunate to have Gary Mitz amongst us. And over to you, Dr. Gary Mitz.
I'm going to start this symposium with a talk that was asked to give about IVUS versus OCT, where to invest when you have to choose only one. Let's start with IVUS. We have 20 or more years of robust data, and the limitations are well understood. The newcomer, which is OCT, has a bright future. Interventionalists who have rejected IVUS or could never learn to interpret the images will perhaps give intravascular imaging a second chance. The images are exquisite and seductive. Compared to IVUS, advocates of OCT cite superior resolution, enhanced imaging during flushing, ease of image interpretation and detection of dissections, tissue protrusion through stents, malposition, other findings not seen on IVUS. And interventionalists are convinced that they know how to interpret the OCT images even when they are wrong. There are many clinical questions that we must answer in the cath lab. I've listed a few of them on the right, but the two most important are whether a lesion is flow limiting and how do I optimize acute stent results. So basically in the cath lab, you have two decisions. Do you treat a patient in a lesion? And if not, or if so, how do you get the best possible result? There are 3 randomized trials that have established FFR as the gold standard to decide whether or not to treat a lesion. It provides lesion-specific assessment of a stenosis relative to the amount of myocardium subtended by the vessel. Can we get the same information with imaging? The answer is no. In non-coronary lesions, these are all the studies that have been presented or published, and you can see that the minimal lumen area cutoff that correlates with abnormal physiology varies from 4 square millimeters to 2 square millimeters, smaller in Asian patients than in Western patients, and therefore, if there's no consensus as to the criteria, how can we rely on this technique? And OCT is no better. So in non-left main lesions, we cannot replace FFR with either IVUS or OCT. In left main lesions, there is equal data for equal data for FFR shown here in the study by Hamilos, and in the study from Spain, a registry called the Litro study, in which patients with a lumen area above and below 6 square millimeters were either treated medically or with vascularization with equivalent outcomes out to 2 years. However, when assessing the left main, because of the problems with having to flush and clear blood out of the left main while having the catheter in the left main, OCT is inferior to IVUS in assessing left main severity. So at least in assessing lesion severity, non-left main lesions is the province of FFR. Left main lesions is the province of either FFR or IVUS, and OCT is simply out of the picture. In terms of predicting adverse events with stent implantation, we have robust data with IVUS in terms of bare metal stents showing that stent under expansion, edge problems, and stent length predict early thrombosis as well as restenosis. And a meta-analysis of 7 randomized trials of IVUS versus angiographic guidance in the bare metal stent era, showing that IVUS guidance reduces restenosis, repeat revascularization, and overall MACE with no impact on myocardial infarction and death. We also have huge literature on IVUS predictors of early thrombosis and restenosis in the DES era, again under expansion and edge problems. We have cutoffs indicating what the minimum acceptable IVUS lumen stent area is with Cypher, Taxus, Xience, and Resolute. This is one just study looking at Guidance in Left Main Intervention from Seoul, Korea, indicating that depending on whether you're looking at the LAD ostium, the circumflex ostium, the polygon of confluence, or the left main proper, we know what minimal stent areas are associated with freedom from repeat revascularization in the future. We also have meta-analyses in the DES era. This is a meta-analysis of 11 studies comparing IVUS guidance with angiographic guidance, showing that IVUS guidance and DS implantation reduced death, stent thrombosis, and major adverse events. And now a larger meta-analysis of 3 randomized trials, 12 registries, and 25,000 patients, showing that IVUS guidance reduces death, MI, stent thrombosis, repeat revascularization, and overall MACE. This is in press in JACC image interventions. To show you just one of these studies, ADAPT-DES was a study looking at predictors of stent thrombosis in drug-eluting stents. There was a pre-specified comparison of IVUS guidance versus lack of IVUS guidance, 3,300 patients with IVUS-guided group, 5,200 patients in the angiographic guidance group. At 1 year, we have a reduction in stent thrombosis and myocardial infarction. Here is the relationship between IVUS use and stent thrombosis within 1 year, a 50% reduction. And here is a reduction in myocardial infarction not related to stent thrombosis with IVUS guidance, again, about a 50% reduction. This is especially true in patients who are presenting with ST elevation MI, shown in the upper left, intermediate in patients presenting in non-STEMI, and these were superior to patients presenting with stable angina. So this is the first evidence that IVUS-guided STEMI and non-STEMI treatment was associated with reduction in MACE at 1 year of follow-up. And this data becomes even stronger at 2 years of follow-up in the data that we just analyzed for submission to TCT. What about OCT guidance? Well, compared to large number of studies in 25,000 patients, we have one registry from Italy comparing 335 patients with OCT guidance to propensity score matched patients with angiographic guidance, showing similar reduction in events. But the OCT findings that were associated with reduction in events were not subtle malapposition, plaque prolapse, and so on, but the same kind of major findings that we saw with IVUS guidance. And in a very small Japanese study comparing OCT and IVUS guidance, you saw a reduction in, improvement in stent expansion and less edge plaque burden in the IVUS guided group compared to the OCT guided group. While I say that I believe OCT has a bright future, the future is not yet here. The investigators in OCT, despite more than 5, 6, 7, 8 years of this technology, have produced very little valuable clinical work. They need to develop a new paradigm for selecting stent length and diameter that does not rely on visualizing true vessel dimensions as is possible with IVUS. And they need to develop endpoints for stent optimization that may be as robust, that should be as robust as the IVUS endpoints. Some may be similar to IVUS, but others will be different, and it is not possible to simply extrapolate measurements from IVUS to OCT. As you can see here, there are only 2 very small studies comparing IVUS and OCT after stenting, and they show somewhat different results in terms of, for example, the minimal stent area. If you look at the bottom table, in the Becerra study, the measurements were virtually identical, but in the Kubo study, OCT was smaller than IVUS by about 0.25 square millimeters. And in terms of left main stenting, IVUS is clearly superior to OCT simply because of the problem in flushing and being able to visualize the entire stent in the left main. So if we're talking about the second most important use of intravascular imaging, which is to optimize stent implantation, we know what we have to minimize with IVUS, and we don't quite know what we have to minimize with OCT. And the question is, will the major differences or the major findings seen with IVUS be sufficient, or will OCT find new causes of stent failure that must be minimized? So we get to the second major use, as I've shown here, stent optimization. There's tremendous data with IVUS, minimal data with OCT. There are also, however, many other uses of these imaging techniques. Identifying culprit lesions in patients presenting with ACS, identifying vulnerable plaques, predicting distal embolization, and assessing stent failure. And I'll simply say that in these secondary uses of intravascular imaging techniques, OCT is clearly superior to IVUS, and that's where most of the work has been done. So today, the two major uses of intravascular imaging in physiology are assessing lesion severity and optimizing PCI. FFR should be used to assess the severity of non-left main lesions, and either FFR or IVUS can be used to assess left main lesion severity. There is a plethora of clinical data on IVUS criteria for optimizing stent implantation and predicting adverse events, and the benefits of IVUS compared to angiography alone. There is little data, one study, on OCT. OCT clearly has niche indications, identifying culprit lesions, assessing causes of stent failure, such as knee atherosclerosis, and so on. In the future, however, it will probably be individual preference whether to use IVUS or OCT to optimize stent implantation. Finally, the world of IVUS is not sitting still. Unfortunately, IVUS technology has not fundamentally changed since its inception. And some of the parts in the devices or the catheters have not changed at all in 25 years. Image quality, in my opinion, is still suboptimal and is being tested by the beautiful images shown with OCT. Image quality varies from patient to patient and catheter to catheter and often requires expert interpretation, inhibiting the confidence of new users and remaining a primary obstacle. So what if we could start from scratch to design and optimize a new IVUS system with transducer, catheter, interface console, and so on, using modern technology as well as 20 years of knowledge? And what if this did not have the limitations of OCT? What if this could be imaging in a blood field and could penetrate to the adventitia? These are some in vitro cadaver images obtained with new generation IVUS, high definition IVUS. You see superior resolution without loss of penetration. And it is probably this new quality of IVUS images that OCT will have to compete against. Thank you for your attention.